Hello, welcome everybody to the No Normal Show for Thursday, January 14th, 2021, brought to you by Revive Health. This is our weekly deep dive into how hospital and health system marketers can navigate what we call the no normal. I'm Chris Bevelo, Health Systems Practice Lead at Revive Health and your host for this show. I'm joined by Chase Kleckner, who is Senior Marketing Manager at Revive Health and our show's producer. Hello, Chase.
Hey, Chris. Good to see you as always.
Good to see you too. And we are also very thrilled to have joining us Tim Nguyen. Tim is the head of Unit for High Impact Events in the Global Infectious Hazard Preparedness Department of the World Health Organization's Health Emergencies Program. His team manages the WHO Information Network for Epidemics, a platform to unite the work on managing disease infodemics during emergencies, and the strategic global governance of pharmaceutical interventions, including pandemic influenza and smallpox vaccine, as well as influenza antivirals. Some notable accomplishments for Tim. He managed an initiative at the WHO founded by the GAVI Alliance to provide 40 million doses of vaccine to most at-risk populations in low resource settings. Joined the WHO's Global Influenza Program, participating in global response work to the first influenza pandemic of the 21st century, and is a founding member of the WHO's Global Hepatitis Program and project manager for the development of the first WHO treatment guidelines for HCV in 2011. Tim, welcome.
Thank you, Chris. Thanks for having me on the show.
Yes, we're very excited to dive in with you. We'll get to you in just a second. We've got housekeeping notes we're going to get through quickly for everybody before we get started. If you're new to the show, this is a podcast in which we share industry trends, research, stories, ideas from those within the hospital and health system world, and like Tim, from those from outside that world, wherever we can find ideas and content to help you all navigate what we call the no normal successfully. If you want to know a little bit more what we mean by no normal, the principles for navigating what is clearly the no normal, what we're living in right now, check out a blog post we wrote back in 2020 that has more on that. Chase will provide a link in the chat function that you can follow. Also watch that chat function for other links that Chase may be providing as we go along. You can also use the chat function to talk to other participants who are live here on the podcast who have joined us. If you have a question though for Tim or myself or Chase, please put that in the Q&A queue of Zoom, which you can see down at the bottom. That's what we monitor to make sure that we capture any questions. And one thing I should note here, and we'll kind of filter this as we go. Obviously, the WHO is a very large organization. There's a lot of stuff going on with the WHO. Even just today, there's some things in the news. We're really excited to have Tim here. He's going to focus on the idea of infodemics. What does that mean? Particularly how we have to deal with that in our world of hospitals and health systems. So we may not be diving into other aspects of WHO work, just to keep us focused on what Tim is here for. Though Tim could speak to, I think, many things. We want to kind of keep it focused today. So keep that in mind as we go through this. If you're new to this, you can subscribe, or you didn't know if you're new, but now you do. You can subscribe to the podcast on iTunes or wherever you listen to podcasts. We also post a recording of the show by the end of the day, a video recording. You can visit our website at thinkrevivehealth.com/COVID-19 for that recording, which again should be up by the end of today. So with all of that, Tim, why don't you start by just kind of describing your role, which I gave kind of a very high level overview of, but give us a little more in depth about what you do and where you've been focusing your efforts as it pertains to COVID-19, the coronavirus, for the last 10 months to a year.
Thanks, Chris. Happy to do that. Of course, many staffers in WHO, kind of have been repurposed, in the last 12 months to focus on a specific aspect of the COVID-19 pandemic response. You mentioned earlier, I'm also working on vaccine allocation and equitable criteria to do that. But right now, in the last 10 months, 12 months, I'm really looking at the aspect of infodemic, risk communication, and engaging communities in the response. I think there are different pillars of response, how WHO supports technical support to countries. You have colleagues working on the vaccine front, people working on the laboratory and diagnostics, people working on the epidemiology and collecting the global intelligence around this. And myself and my team, we're looking at this concept of infodemics, what that means, how it affects individuals and population, and how can we provide solutions and interventions to mitigate the harms from an infodemic. Happy, if we have time to go more in detail around this, but that's, how I've been occupying myself the last 12 months.
Yeah, I'm sure you've been very busy. And let's dive in on a little bit on infodemics, because, I think for maybe somebody in your world, that's not a new concept, though I'd love to hear from you on that. But I think for most of us, our experience with something like a pandemic, this is really the first time for just the average folks, even in our space, who've had to deal with this. Of course, if you work at a hospital or health system, I'm sure there were things going on with SARS and other potential pandemics or actual pandemics. They just never hit the United States like COVID-19 has. And so the idea of an infodemic is really fascinating to a lot of us. And I know that the WHO hosted an event last month, the third virtual global WHO Infodemic Management Conference. And I know you were a big part of that. So why don't you talk to us about what that event was all about, as maybe just the first step in talking about infodemics?
Thank you. I think you rightly pointed out, it's not a new concept, but I think that now with this pandemic, we all feel it. And I think, even the word itself, information epidemic, it's a melange of these two words, and it makes sense to people because in one way or other, they know what it means to them intuitively, either through the means of I receive too much information on television, or I receive suddenly too much information on my WhatsApp feed because my mother sends me information she just heard about from another friend, and what do you think about this? And it makes also sense from the scientific point of view. The vast amount of scientific publications that have risen since the beginning of this pandemic. I think in a Nature article recently cited that there was about 25,000 research articles published from January to August alone, just on the COVID. So imagine this: we have, a WHO department just sifting through all these articles and trying to find what makes relevance, what makes sense to help us formulate better guidance to individuals and countries on the situation. So from all this aspect, each of us in one way or another feel there is this impact of infodemic. Just, to deep dive a little bit what we mean by an infodemic.
Yeah.
It can be both, it can be too much good information or too much of the bad information happening. So I'm very vague here, but give me some examples. The bad information, of course, we're looking at the issue about misinformation and disinformation. Now, misinformation is the kind of information shared that is not correct, but without an agenda. It's like you and me, and it happened to me myself that I saw something and I liked it, and then with second thought, I should have thought about
right.
Before sharing this. I should have checked the sources. And no, actually, this does make sense if I'm looking into it, but I was lured into it because of the emotional language that are happening, and this happens to all of us. Disinformation is a kind of false information with an agenda. There's a political interest, there's an economic interest in this, or just people want to have more popularity, but they know it's wrong and they do it with an agenda. So that's the kind of mis and disinformation we're looking at, and understand better how that evolves, how that spreads, how it takes traction and velocity. But we also see the issue about too much information. When there's too much out there that people make sense of it. I mentioned earlier the scientific research. Science is important for us, but of course, at the moment, it's too much, and not all makes sense. Not all is peer reviewed. So,
Right.
and that also makes us, challenging to understand what is really relevant for us to find the right information. And that's only from a scientific point of view. But imagine, our parents who might not be so, digital fluent,
Right.
and understanding what are the trusted sources on the internet. or who to trust more than others, because other people can be quite persuasive in their argumentation and in their narratives, and then people who might not have the right level of health literacy to distinguish this. And then, this leads then them to share information that is not accurate, and that becomes misinformation then. So it's a fascinating new environment that's happening, and it's just really that everybody in the world is affected at the moment.
Yeah, it's incredible to hear you talk about it, because it's just the different dimensions of it. I typically think when I think about something like an infodemic, like you said, there's too much information. I often think of the misinformation and the disinformation, but just like you said, there's 25,000 published articles of some kind of scientific level. Now, of course, not all of them are, like to your point, peer reviewed. But even if all we were talking about is what scientists are putting out there, even reputable scientists, even peer-reviewed scientists, journals, articles, or reports or research, this would exist. And I think where this comes home for a lot of us is, and I've said this before, again, this is for a lot of us the first time we've experienced anything close to this. To the degree to which this applies to some of the simplest things. So we're talking about a global pandemic. That's redundant. We're talking about a pandemic. I'm trying to get out of that habit. Somebody pointed out that global pandemic is redundant. So just understanding the disease COVID-19, how it spreads, how to treat it, what's effective, that is huge. Thinking about vaccines, that itself is huge, because we've got multiple vaccines. And we can talk about a lot of this, Tim. But the simplest thing, at least for someone like me, of, hey, it helps to wear a mask. And we have seen in this country how that, which should be a pretty simple thing, you would think, all of the elements that you described apply to something as simple as, hey, we should just wear a mask. Forget about all the bigger multidimensional things. And that's where I think, I don't know how you all do what you do. How do you grapple with all of this?
The point is, it's a process, right? We're already 12 months into it, and as new data, new evidence comes, we're also adapting, and our guidance and understanding around this. COVID was a new disease. The virus was new. Then, the diseases that it causes. So in the beginning, it was a lot of understanding and learning. And actually, what happens often in disease outbreaks, it's not scientific publication then that is existing, but it's networks of friends and experts that already pre-existed. So WHO, have a lot of expert groups around the world, and we can tap into these resources. And then it's an exchange of information that then in the beginning helps us to understand the situation and formulate our first guidance around this. And as the scientific process kicks in and more information is then also publicly available through a scientific process, then that helps us then to formulate throughout the process and updating information to the public that they can rely on. And I think it's important to have this infrastructure established. That's why response is only one side, but preparedness is the other part of this. So in terms of infodemic, we already started, in every kind of disease outbreaks at a smaller scale, right? We have already risk communication and community engagement efforts going on to help communities to understand this situation, to work with religious leaders, to work with community leaders on this topic. For us, and this is important, risk communication cannot be a top-down approach where an authority and even WHO should not be there and say this is what you should do. But what we need to do is work with communities to adapt messaging that is culturally appropriate, that is language appropriate, because how you communicate maybe in the US health system is very much different how you would do that in DRC Congo. When you meet other populations and communities that have different infrastructure. And I think this is a very important, process, we're taking.
Yeah. I want to ask you too about another dimension of this, which also makes this, I would imagine, really difficult to manage. And that is, we're not talking about a point in time. We're not talking about a set state of affairs or facts. I mean, I brought up masks. So, to be fair, going back early on, there was messaging in the United States from health leadership, respected health leadership, saying, don't wear masks. And that wasn't because they weren't effective. It was because at the time we had to save those for our healthcare workers. And then that message changed, appropriately so. But we also know that the COVID-19 itself changes. And we're already seeing variants across the globe. And so even something that might have been, hopefully not vaccines, but something that might have been effective or appropriate today, a week from now, a month from now, 6 months from now, we may have to change how we think about it or how we approach it, which is just a whole nother variable that folks like you and others have to manage.
Thank you. Yet you raising exactly this example about masks. Scientific evidence is one thing that is very important, but then also you have to see what is public health feasible in the moment to apply to a certain context. And you rightly pointed out in the beginning, there was a shortage of masks. And of course, many governments wanted to prioritize, the limited supply they have to healthcare workers, that because they were the most exposed at the moment when treating and when seeing COVID patients. And only later, there was more evidence around that also maybe a fabric mask, is helpful of limiting the spread of the virus. It does not limit from you contracting it, but it reduces the risk of spreading if a lot of people are doing this and still keeping distance and still doing their hand washing hygiene. So it's a combination of interventions that we call non-pharmaceutical interventions. So if you don't have vaccine, if you don't have medication treatment, these are interventions we all can do, but often it's a combination of this. Sometimes we refer to this as the Swiss cheese model, right? With a Swiss cheese layer has holes and maybe one intervention doesn't work because it still works. But if you have a lot of layers, then the combination of layers protects and support those non-pharmaceutical interventions. And this, we had to carry together this information. A lot of these models were based on influenza and the research and the preparedness done around this. But also what we learned is that COVID is different from influenza in some aspects. So a lot of adaptation of the evidence and guidance needed to happen. But we cannot just say we have to do it like influenza. But first, what is the evidence around this, and how can we interpret that information to apply to an evidence-based approach when we propose interventions?
Yeah, that is all. That's right. And I know that we want to talk a little bit about how folks, because the folks that are here with us on this call and who listen to the podcast, oftentimes are tasked with grappling with how an infodemic is affecting how they communicate from their organizations and what's important and the challenges they have. So we're going to get to some, I think you have some tips or some important ways to think about infodemic. But first, why don't you kind of explain, I think it's interesting, there's kind of 6 different categories that you use when considering an infodemic. Why don't you just briefly outline those? Because I think it's a nice kind of framework to think about this.
I think there are several frameworks we're looking around, right? So for me, infodemic management, so how we can approach and tackle this is really looking at 4 key dimensions. The first dimension is listen to concerns, understand the concerns of individuals and populations. So we really need to do the effort of understanding why people believe certain things or why people do certain things. So, and that needs to have an active approach to do this. For example, you can do through different surveys or kind of what we're doing now, a digital listening approach, where we use AI technology, linguistic analysis to really understand what's happening on social media and what are the common stories people are sharing, what are the common questions they have. And by doing that, we can then adapt our Q&As around, okay, for example, a couple of months ago, a predominant question was, how does a pandemic end? And so then, how do we adapt Q&A to address these kind of questions people have? The second very important thing for us is the way we need to distill science and make it more approachable to a lay audience, right? Research has its own terminologies, their own processes. And if you're not a researcher, it's even very hard for even academics to understand the scientific discourse in a certain discipline and how that happens. Science often works around falsification. We have an hypothesis and we try to falsify what a different researcher has established at one point. And that's a breakthrough. I have found a better way to do it, or I have found an alternative result to what another research team has already done. And that is called sometimes a breakthrough. And we need to understand that it's a competition sometimes, but this is not how the lay people understand it. So we have to do an effort to translate and present evidence in a way that is more susceptible for people to understand. For example, a great thing that happened in the beginning of the pandemic was the flatten the curve GIF image you have. I suddenly saw everybody was sharing this because it was showing people, hey, this is your impact when you do this. When you wash your hands, when you keep distance, when you wear the mask, this is how the epidemic curve flattens. When it flattens, it means less people go to hospitals. It's not overburdening our health system. And that's a very complex matter to explain to people, but to this GIF, suddenly people got the grip out of that. And I think this is the way we need to go in the future, working with this human-centeredness about how we present this kind of information, how we break down and distill science. So that's the second thing we need to do in infodemic management. The third thing that's very important is for me to build resilience to misinformation. And I would like to stress here, this is not taking away misinformation, correcting it all the time, and because that's the last resort. That's already at the back end when it's too late. I think what we need to do is to make people understand there is misinformation out there, to show to them what the mechanics are around this, how they can see this is a misinformation. Often, for example, look at the date stamp. Sometimes you have a date stamp on a picture. People are not looking at it, but then suddenly it says 2013. So maybe it does not match the 2020 situation. Or it shows a situation that a group of people marching to the mayor's house, and then suddenly, no, this was a demonstration for a different topic.
Right.
And these kind of tools exist already, and we need to increase this kind of literacy to people that they can spot misinformation themselves. It's like going back to the 90s when we tried to teach people around health promotion about HIV/AIDS. That prevention is better than contracting the disease. So wear a condom. Now was the key message in the 90s for HIV/AIDS prevention. And I think we are kind of this stage in this digital age. We need to teach vast majority of the population to understand there is this disinformation out there, but it's not about censorship. It's not about correcting all the time because we don't have the resources, but to build the resilience in communities to understand this, that they're not sharing this and that they're calling this out. For example, one of the projects we would like to do is the kind of a misinformation emoji. Instead of people saying, hey, you're wrong, or hey, what are you sharing? Maybe sometimes it's like an emoji. Have you checked the source? Are you sure what you're just sharing is correct? This is just an idea, we have, and seeing how we can create this kind of innovations.
I think it's so fascinating to me because I make the joke of, I can remember, I don't know when this was, late 90s, 2000s, when you would say, I saw it on the internet, so it must be true, ha ha. And everybody got the joke. Everybody understood that, hey, if you saw it on the internet, the odds are good that it's probably BS, it's probably whatever. And, obviously things have advanced. There are so many more ways that people get information through the internet, through social media. I think social media is really what changed that dynamic. But certainly we're in a place now where that is not an ironic statement. That is what many people believe. I saw it on the internet, so it must be true. And there's no ha 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 after. And it's a massive issue.
It has totally flipped. And I think if we ask healthcare providers, they will say that that's what they're confronted with. Patients come and say, I read it on the internet. And the healthcare provider is now on the spot to say, no, that's not correct. Or
Right.
no, that's not true. My personal expert view is this. But they saw it on the internet. They see a lot of people liking it. So there must be something true around this. And that's a lot of discussion I hear from healthcare providers, that they have to find information off what people read on the internet.
Right. That's right. So you said there was 4 dimensions. You've covered 2.
Yeah. So the third dimension was, building the resilience to misinformation. And the fourth dimension is really engaging and communicating with communities. I think this is, where trust needs to build in the communities, with local healthcare providers, with religious leaders, even with your employers. People, we are listening to different people in our life, to our parents, to our spouses, to our neighbors, to our faith leader, and also to our employer. And I think this is where we need to engage with that. They can amplify the correct message. And this is where WHO is very hard working now. For example, we call it the world of work. So we try to engage with unions, with a chamber of commerces, that we can also, through those employers, that we can also amplify good health information, that they can reach individuals, and also have different ways then to listen to somebody else and just maybe WHO, about what could be the right behavior to take during the situation. So these are the 4 key dimensions we see in infodemic management. And of course, and we don't have the time to go through all these dimensions and all the ideas and projects that we have, but maybe I can refer to, we have a 50 action point framework on our internet that summarizes 50 key actions we can take globally to fight the infodemic. It's called Managing the COVID-19 Infodemic Framework. And here, you can get some ideas what 50 actions, can be summarized under these 4 key dimensions.
Okay, that's great. Chase is going to hunt that down for us. I can see him hard at work trying to find it.
Yeah.
You want to tell
earlier? Yeah.
Oh, go ahead. No, go ahead.
No, and I think earlier you mentioned, to these 6 key stakeholders we see that can contribute and support. So this is what our December event was about.
Yeah.
We had 6 key sectors coming back and reporting back from actually a 6-week consultation process. So from October to December, we ran about 21 events with 6 what we call key sectors that can contribute to mitigating the infodemic. Had about 290 panelists talking, 5,000 people participating in this discussion. And we asked, these 6 sectors, what are your key challenges? And what do you think, can you contribute to mitigating the infodemic? And, for this conference, the 6 sectors we identified was, what can the science community do? What can media and journalists do? What can health authorities do? What can the tech industry do? What can civil society and NGOs do? And 6, what can the UN family do? So we had, these 6 sectors just coming back from this area, or this series of consultation, and summarize to us, hey, this is what we heard, and this is what we can do, and it's a long list, and we will be publishing a report from this shortly. But happy if you're interested in to talk a bit more about some of the sectors and what they say.
I am. There's one that just fascinates me, and we could dive into all of them, but I'm so curious about what you heard or what you think about the tech industry, because I think obviously we have the infodemic, but we also see the impact of particularly social media. So let's just throw out Facebook, Instagram, WhatsApp, Twitter, Parler. So you've got all of these social media platforms that are that are in some part responsible for the acceleration of misinformation, acceleration of disinformation. And what I'm curious about is how much do they recognize that? I think you've seen an awakening recently from some of them, but sometimes I think, as an example, the idea of a piece of misinformation comes up about vaccines, and they will apply like a little badge to it saying this is not proven, or this is misinformation, or this is not accurate, whatever. And what I wonder about even is how effective is that? Because if these folks are in, we're all in our bubbles and we're all hearing what we want to hear, and there's a growing almost us versus them with the tech companies. So if Twitter puts on my post, this isn't accurate, do my followers believe it if what I'm saying fits what they want to hear? So I just wonder how you put the genie back in the bottle. How can you combat an infodemic with the tech platforms?
Thanks. There are actually several questions within
Yeah.
what you're asking. So let me a bit dissect a bit, in terms of what tech industry is doing at the moment to support the COVID-19 pandemic infodemic mitigation, but also to understand better what's happening on social media. So that goes more into the social science research around this. So for that later part, actually, we had a different conference in the summer. We called it the Infodemiology Conference. And basically what we want to find is to all the interventions we are proposing to fight the infodemic, what is the evidence around that, if it works or not? How do we know how misinformation is being shared on social media? When does a piece of information jumps platforms? So it goes from Twitter to Facebook to Reddit and so on. Is that then what we should call viral, when it makes those jumps, or just stays within the community? How are different people living in their bubbles, in their communities? Does it make those jumps and so on? So we actually organized a conference around that to collect priority research questions we want to put out to academia to research this specific topic for us to understand much better what's happening. One piece of evidence that was published is very interesting, comes from Neil Johnson, and that predates COVID-19. So in 2019, on one day, he analyzed 100 million Facebook users and wanted to understand, hey, what is their position towards vaccination in general? And he saw, that this 100 million users, form kind of 800 different clusters or groups. Like a group could be, I love dogs. So I'm in that group, dog loving group. And what he found out is that the vast majority of those Facebook users, about 80%, is indecisive, right? If they swing over to, I'm for vaccination, or I rather don't want to get vaccinated. And then the minority group was actually those ones who would not take a vaccination, and who would also be quite vocal around this. So that was the minority group compared to a bigger group that is pro-vaccination. But what this research showed is that those people that are against vaccination are much better connected to those 80% that are indecisive. So they share the same groups where those people are. Like, I like pizza. So, you have maybe, a big group of pizza lovers, and most of them are undecisive, but the ones that, are against vaccination are better connected to this group and have a better influence. And that's a very interesting piece of information that he found out. And this is the kind of research we need, how are these environments are living? We have to change our concept of community. Most of the time, it's a geographical concept. Like a community is where you live. But right now with social media, we have this new form of communities where, I'm randomly connected with some guy in, I don't know, India, but we share common interests that are connected to this. And this is also now suddenly forms a new kind of community where we share information.
Yeah, that is so true. And especially for the last year, as so many of us have been if not constrained to being at home, at least, spending way more time isolated from geographic communities because of COVID. And so that's only going to grow. That dynamic's going to grow. Do you have?
And here's
No, you go ahead.
Yeah, and this is the second aspect I wanted. Why the tech industry has such a big important role to play at the moment. With many countries going or asking for stay at home or working from home. Of course, this is the way we stay connected to many people, and our conduit then to also ensure some kind of level of mental health. We are social beings, so we need this connection. And if we cannot have this physical connection, that's at the moment for billions of people the default how they can connect. So there's a big role tech industry have, to ensure that people can stay connected, that we can work actually. This conference, ideally, we would meet in person. Right. But we're doing now over social media. Most people work from home at the moment. So without these technologies, this actually would not happen. But WHO itself is very grateful to many tech companies because they have proactively worked with us from the beginning to help promote good information. If you go on Google and type in certain words, you will find that it's being redirected to authoritative, trusted resources like the WHO, like the US CDC, like your local healthcare providers. So people, already now through this collaboration see and have access to better information. Same with Facebook. There's this COVID information center. So when you look for this, there is a redirection to this kind of information. Also, what you mentioned earlier with Twitter, already marking, in terms of this could be misinformation. But if you look behind, it's not Twitter itself, but they're working with a lot of fact-checking institutions at the moment to make this support and to help in terms of identifying what could be misleading and helping people to redirect this. Some research show, what is the best way to tackle misinformation, and there are different techniques. But some of them show it's as simple as just saying stamping this as false or true. And it's more intuitive than to people. But here again, and it's very important, who are the trusted sources that can make that decision? Right. And here I think we need to establish standards around this, that it's the same around platforms. Right now, it's the Wild West. Everybody is willing to do something, but there are no standards. So each platform have their own governance mechanism around this, their own ways to do it. But I think, and also increase trust in these systems, we need to work towards, developing some kind of standards, some kind of transparency, how it's being done. And this is where, for example, result of our conference in December was that the UN agencies have an important role to play to maybe establish, these standards. We from WHO look from the health perspective, but colleagues from UNESCO, they look more from the freedom for expression of interest and kind of perspective on information, that there is no censorship in terms of expression of opinion, that journalists who may say something that is then not being censored then in a way that because it's a different view perspective given to that we need to ensure freedom of expression and this kind of very important rights issues. And I think this is where the future lies, that we work collaboratively with the different sectors, especially the tech sector, to establish this thing, because this is then building towards trust in that system and people understanding how it works. Right now, something is maybe good intended, but it seems randomly. Right. And then when there is this random aspect, people lose trust. Yeah. Because they don't understand, and there is no standard. Why is one institution doing it this way and others doing it this way? Yeah, absolutely. We're coming to near the end. I want to give you a chance to answer one more question for me anyway. If folks have questions for Tim, please put them in the Q&A. And we've got one lined up there. I just want you to kind of close by, that the folks listening here, primarily from hospitals and health systems here in the US, what 2 or 3 bits of advice do you have for them as they struggle to battle
through the infodemic in terms of helping their organizations communicate clearly and effectively around COVID-19?
I think there are a couple of things I would like, to share. The first thing is, that healthcare providers, physicians, nurses, doctors, they must realize that they are the most trusted sources in many countries. Also in the US, I think we can look at a recent survey from Johns Hopkins, MIT. They have a nice dashboard developed about attitudes and perception around the world on COVID and different intervention. And the most trusted source are people in the communities, your doctors, your nurses. So you have an important role to play to build that trust in the response. And this is far superior than the social media. It's 11%. So right. 67% is of respondents say this is my trusted source, and only 11% said it's the internet. So I think that's first. We have to realize this. The big majority and power we as healthcare providers have in understanding this concept. The second thing is we are role models then, in terms of how we communicate and how we share. So I think we as a community need to have the right messaging ready and develop for different questions that patients might have when they come to us. And talking about, the vaccine, many questions we receive from people. How is it possible to develop a vaccine in 12 months when other vaccines, took a decade to develop? And I think, but there are good explanations around this, the global effort invested into the development, the funding that was provided, the collaborative approach of sharing information, new technologies that are emerging to help this, and of course, investment from governments into systems to develop this. And also, in terms of the research project, and clinical trials process that was, adapted to this without compromising on the safety. Instead of doing phase 1, 2, 3 consecutively, there were ways, to do this in a way that it's sequenced and in parallel. And it's not the first time. We did this also with the Ebola vaccine when we had the big West Africa outbreak in 2014, 16, and also now in 18, 19, that, this vaccine was also developed, using a fast track approach, and it worked well. And I think this is the kind of information we need to be ready and able to communicate and assure people that come in. The third thing we need to understand is vaccine mistrust is greatest in marginalized populations. And it's not because not the trusting the vaccine, but not trusting the system they are living in, because they have been deprived from sometimes good access to health systems and explanation around this. So it's rather a mistrust in the system itself than in the vaccine. And we must understand this and be ready, to communicate around this. I think these are the three key things I would like to, to share and have, your network consider when they move forward around this and tackling the infodemic.
Yeah, you have a few more, or those are
these are the three.
Okay, got it. I thought those are really good. So if you had more, that's fantastic. That's a bonus. One more question that came in. We're talking about individual hospitals and health systems, particularly in regards to the vaccine, who are being given the responsibility of distribution in many communities in the U.S. Do you see a different role? And if so, what would that be for some of the associations of these hospitals? So we'll say like the American Hospital Association, or in every state in the U.S., we have state hospital associations. Is there something different they should be doing or thinking about? Or is it's kind of the same advice and approach that you would have even for the individual hospitals?
I think vaccine distribution is a very important point, to do that equitably and within, the agreed priority list. And I understand that, that the system, in different countries work differently. I'm not so intimately involved in how vaccine distribution works in the US. My focus is more in low and middle income countries and establishing those mechanisms. So there, most of the time, it's through the public health institutions and government institutions that in the beginning, vaccine is scarce, and we must ensure that the priority groups receive this, where the impact could be highest in the beginning, and then move while more vaccine will be available to other distribution forms. So I cannot intimately answer how in the US this works. For me, it's just the basic concept is really that it's difficult if once hospital follows certain rules about we first vaccinate the elderly above 58, then the next age cohort, of course, healthcare workers that have high contacts to these individuals. And then if another hospital follows different rules, then you have the issue around them that is being shared online, that why is here in state X distributed this way, and in a different state and community it's distributed this way, and that causes, of course, discourse online, and this information is so readily available. So that's the key issue. If we in a certain community and context don't adhere to the same principles, this will be officially shared and it turns against us, even if they are good intention, but it turns suddenly against us. So it's very important that everybody understand the clear criteria, how things are being distributed to our priority groups, and that we adhere to that.
Yeah, unfortunately, that is the situation here. It's basically like 50 different paths. And of course, a lot of them are similar, but they're not all similar. There's not a singular path. There's not a singular plan. And I think that just adds to the infodemic and what you're talking about. And I would just add to that question, if it's important for hospitals and health systems individually to stand up as leaders, as you say, Tim, because they are the most trusted resource, then the state associations and national associations like AHA have a role to help them pool their voices and expand and share those voices even on a broader platform, because they have a broader platform. So I think that is something that those organizations could definitely do. We're running out of time, Tim. I feel like we just keep going on and on and on, but this has been fantastic. We so appreciate you having the time to join us and sharing what you guys are doing there at the WHO. Thank you so much for joining us.
Thank you, Chris, for having me.
Absolutely. Chase, as always, sir, thank you for being here.
Yeah, I really enjoyed it. Thanks so much, Tim.
Thank you, Chase.
Next
Have a good evening, everybody.
Yeah. Next week we will evening, because you're in Geneva. I don't think we told people you're in Geneva, so it's evening there for you. Next week we're going to be talking a little bit more about vaccines and the issues that we're seeing hospitals and health systems dealing with, and hope to have Christian Barnett, who leads strategy group here at Revive Health, talk about some things that we've learned and ways to think about how we might do a better job in terms of vaccine communication and that type of thing. So definitely tune back in next week. Thank you all for joining us. And until then, good luck out there in the no normal. Thanks, everybody.